Hi everyone, welcome to our Next Gen NCLEX RN review session. In this episode, we'll be working through a case study using the clinical judgment measurement model as our guide, and we'll be tackling 6 Next Gen NCLEX questions, and I hope that you're going to complete the entire test practice. Let's begin. So this is a case of a 58-year-old male who presented to the clinic accompanied by a friend, reporting lethargy, confusion, intense thirst, frequent urination, nausea, and abdominal pain. And we have the following details in the admission data table. He has no allergies and has medical history of type 2 diabetes mellitus, and this was diagnosed at age 45. Hypertension with recent upper respiratory infection for 3 days, and has prescriptions for metformin 1000 milligrams twice daily, glipizide 10 milligrams daily, and possible missed doses of these 2 drugs. And he is accompanied by his friend. Now let's focus into the assessment findings here. He appears extremely lethargic, confused, dehydrated, with dry oral mucus or dry mucous membranes, and slow to respond, no focal deficits, tachycardic, weak pulse, no murmurs, has clear lung sounds, tachypnic, and has diffuse abdominal pain, nausea is present, and there are no lesions. Skin is dry and warm, and this patient doesn't have any medical alert tag, and has history of alcohol consumption 2 nights ago. Now let's look into the lab results here with a blood glucose of 650 milligrams per deciliter, and his result for urine ketones is trace. So pay attention to these values. Here, your task is to highlight the clinical findings that are most specific to hyperosmolar hyperglycemic syndrome, or what we call as HHS. And showing you here the same tables that I just read just a few seconds ago. We have the history and physical, or assessment findings, I should say, and the nurse's progress notes. Now, I want you to scan one more time the information in these 2 tables, and you can pause this video and you can resume as soon as you're ready to answer this test item. Now, let me go ahead and start answering this question. Now, what do you think would be one of the most important findings that is linked very specifically to determine that the patient has HHS? Well, one of those is this one. We got blood glucose of 650 milligrams per deciliter. This is really high. This is a red flag for HHS. Whenever there is extreme hyperglycemia, this can lead to increased osmolality. So here we are talking about increased concentration of the solutes in the blood, and we're talking about glucose. And this is the main reason why the symptoms are appearing in this patient. Now, the next finding that you should highlight here is extremely lethargic. This level of tiredness or lack of energy shows that the brain is affected. Now, take note that in HHS, the brain doesn't get enough fluid because of the hyperosmolar state, which led to the person's altered mental status. So pay attention to that one. Now we have the same assessment finding, lethargic, and we also have confused as one of those manifestations. This one goes hand in hand with severe dehydration and high osmolality in the bloodstream. And this is one of the classic neurological signs that will help you differentiate HHS from the other conditions. Now, we have other documentations here, same confused, and then we have confused right in the nurse's progress notes as well. Now, next is dehydrated or dry mucous membranes. Well, when this can happen, it's a strong indicator of dehydration. And in HHS, this happens because high blood sugar causes the kidneys to dump glucose into the urine. So this is going to cause pooling water with it, and this is what we refer to as osmotic diuresis. Whenever there is excessive glucose present in the bloodstream, the kidneys will no longer be able to hold that much sugar. So it's going to start dumping those excess glucose, and water will follow the glucose. And that's why there's going to be some polyuria. Now, we have the next manifestation, intense thirst. All right, polydipsia. Here, the body is trying to compensate for all the fluid loss by making the patient feel very thirsty. And this is the body's way of trying to rehydrate. The next assessment finding is this one, frequent urination or polyuria. This is very common in HHS. Again, this is caused by the excess glucose in the blood spilling into the urine. We call that as glucosuria, which is going to draw water with it, and this is going to lead to dehydration. Now, I think we have covered most of those specific manifestations. Now let's talk about those items that we're not going to highlight here. And one of those manifestations is the nausea and abdominal pain. You can find that in the second table right before the nurse's progress notes. So these symptoms are pretty general and can show up in many conditions like a gastrointestinal infection or even sepsis, and they're not really specific to HHS. Now, looking into the patient's vital signs, you are seeing there 90/60, right? 90/60 in their blood pressure. This is low. We also have tachycardia 120 and some elevations in the temperature of 100.4 degrees Fahrenheit or 38 degrees centigrade. These signs show that the body is under stress. It's caused by the dehydration or illness, but they are not unique to HHS. So you'd see the same vital signs in conditions like hypovolemia or infection, but these are not really specific to the condition that we are looking at, and that's why we are not highlighting these. So let's look into the skin assessment findings. You'll see there dry, warm skin. While this does point to the dehydration, but these findings do not really become specific, or they're not specific compared to the dry mucous membranes, which more clearly reflect the fluid loss happening in HHS. Now, let's look into the portion right there at the bottom. You'll see there trace ketones right next to the blood glucose of 650 milligrams per deciliter. So this finding will help you rule out diabetic ketoacidosis, which typically has large ketones, but having trace ketones is not enough on its own to diagnose HHS. And you're going to see there no medical alert tag. It's not really that relevant to the manifestations here. This is just part of the patient's history. But again, these are not actual clinical signs of HHS. So we're not going to highlight that as well. All right, so here I want you to pause and reflect on your answers and compare it with the rationals that I just gave you. And let's resume when you're ready. All right, let's jump into our next test item, number 2.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test, 5,000 real NCLEX questions, practice with actual past exam questions for better preparation, 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says here the patient presents with HHS, blood glucose of 650 milligrams per deciliter, trace ketones, lethargy, confusion, dehydration. He reports missing metformin and glipizide for 2 days, minimal eating, and heavy alcohol consumption 2 nights ago. And your task is to categorize each factor as a primary cause, contributing factor, or unlikely factor for the HHS episode. And you got to make sure that it's matching each cause to the rational. All right. And here we have the following options for the cause. We have stress-induced cortisol release, dehydration from inadequate fluid intake, upper respiratory infection, recent heavy alcohol consumption, missed metformin and glipizide doses for 2 days. And here's the list at the bottom for the rational options. One of those is cortisol from illness, stress, increases hepatic glucose production and insulin resistance, contributing to hyperglycemia. Infection increases stress hormones, promoting glycogenolysis and gluconeogenesis, exacerbating hyperglycemia in the absence of medications. Alcohol 2 nights ago may cause delayed hypoglycemia or dehydration, but is not primary HHS driver as its metabolic effects are transient. And reduced fluid intake during illness worsened dehydration, a key HHS feature amplifying hyperosmolarity, and omitting metformin and glipizide led to uncontrolled hyperglycemia, directly causing HHS. Pharmacokinetic half-lives allowed glucose to rise unchecked. So I want you to glance into the matrix here onto the left side of the table. You are seeing there the primary cause, contributing factor. So there are 3 of them there. And lastly, unlikely factor at the bottom. And towards the right side of the table, you'll see there the physiological consequence. So these will serve as clues to your answers, or your the answers that you will be selecting. So the physiological consequence is basically aligned with the category. So keep in mind about these. So this will be your hint here. So for the primary cause, it said about severe hyperglycemia causing hyperosmolarity and dehydration and so forth. So I want you to pay attention to the physiological consequence. Make sure that each of these will match to the cause and the rationale that you will be selecting. Now, let's get started filling all these blanks at this table. Now, what do you think would be the primary cause for the patient's HHS? So I want you to carefully look into the drop-down options here. So the answer to this one is missed metformin and glipizide doses for 2 days. That's the main reason. And the rationale for this one is omitting metformin and glipizide led to uncontrolled hyperglycemia, directly causing HHS. Pharmacokinetic half-lives allowed glucose to rise unchecked. Now, since the patient reported that he missed taking the medications, we're talking about the oral hypoglycemic drugs. This is a huge deal for someone with type 2 diabetes. because we know that these two drugs are key to keeping their blood sugar in check. And I want you to recall the drug action for each of these. So remember that metformin, it's going to help the body respond better to insulin. It's going to lower the blood sugar made by the liver, whereas the glipizide is going to help the pancreas release more insulin. And since he said that he missed taking these, then the body lost its ability to manage glucose effectively, and that's why their blood sugar shoot up to 650 milligrams per deciliter. And this is going to cause the kidneys to flush all the extra glucose by making the patient pee a lot. So there's polyuria, and this is what we recall as osmotic diuresis. So this is going to lead to very serious fluid loss and resulted into the patient's dehydration. And the bottom line here is that missing these two important medications set off the entire chain reaction that led to the patient's hyperglycemia, the dehydration, and eventually hyperosmolar hyperglycemic state. And that's why we call this as the main cause. So here, you are going to use the physiological consequence in the right column. Again, we have the blood sugar of 650 milligrams. That is your hint right there. This is causing the hyperosmolarity and the dehydration. So make use of those hints. Now, let's move on to one of the contributing factors. What do you think would be one of these factors? Now, let me just say the answer here. That is the upper respiratory infection. Remember, in the medical record, the patient had a recent upper respiratory infection. And the rationale for this one is infection can increase stress hormones. It will promote glycogenolysis and gluconeogenesis, and this will exacerbate the hyperglycemia in the absence of the two medications. So that's why we consider this as contributing factor. Now, I want you to pay close attention here, because when a person is sick, especially when they already have type 2 diabetes, their body releases stress hormones like cortisol and epinephrine. And remember that these hormones can raise the blood sugar to fuel the immune system. And if someone already has high blood sugar, and if they are missing those two important medications, the stress response makes it much worse. So the bottom line here is that the infection did not start the high blood sugar, but it definitely made it worse. And that's why this is a contributing factor. It's not the main cause. And go back into the third column, or the right column, to look for the hint. We have the words elevated blood glucose due to counter-regulatory hormone surge. So this tells you that this is a stress-related effect. All right. So my tip for you, especially in this similar case, infections will show up as contributors because they don't start the problem. They just fan the flames. Now let's move on into the second contributing factor here. So carefully select that option. Now, the answer here is dehydration from inadequate fluid intake. The patient did not take in enough fluids when he was sick, and the rationale, it says reduced fluid intake during illness worsened dehydration, a key HHS feature amplifying hyperosmolarity. Now, when there is high blood sugar, the body is already losing a lot of fluid through rapid or excessive urination, and the patient not drinking enough on top of that makes the dehydration worse. And remember that severe dehydration can raise the blood concentration. There is hyperosmolality, and this can cause the confusion, and in worst case scenarios, it can lead to coma. So the bottom line here is that when the patient is not drinking fluids, it's not really causing the hyperglycemia, but it made the effects of hyperglycemia much more severe, and that's why we call this as a contributing factor. And your clue in the right column, it says increased plasma osmolality, worsening neurological symptoms. So it shows this worsened the effects rather than starting them. Now let's look into the third contributing factor, and the answer to this one is stress-induced cortisol release. And the rationale that we should select is this one. Cortisol from illness, stress increases hepatic glucose production and insulin resistance, contributing to hyperglycemia. Remember that cortisol increases the blood sugar by making the liver produce more glucose and by making the body more resistant to insulin. So this can lead to more issues if the person is not taking their diabetic medications or diabetes medications, and this stress response will push the blood sugar even higher. And the same as the infection that the patient reported, stress didn't start the problem, it just made it worse, and that's why it's another contributing factor. And look into the right column. The clue here is hyperglycemia via enhanced gluconeogenesis and reduced insulin sensitivity. So that's your hint right there. Lastly, we have the unlikely factor. The correct answer here is recent heavy alcohol consumption. Remember that the patient drank heavily 2 days ago. Remember, 2 days ago. And the reason for this, alcohol 2 nights ago may cause delayed hypoglycemia or dehydration, but it is not a primary HHS driver, as its metabolic effects are transient, right? It's been 2 days ago. We know that alcohol can cause the blood sugar, it can mess the blood sugar and can cause dehydration. So those effects usually don't last long, and they tend to lower the blood sugar, not cause elevation. Now, why do you think that this is not going to fit here? It said unlikely factor. Remember that the alcohol happened days before the crisis, and it is not known to spike blood sugar like most diabetic medications or stress hormones do. And the alcohol probably played a very small role, if any, but it did not start or significantly worsen the hyperglycemia. So it's considered an unlikely factor here. So your clue in the right column, it says minor contribution to dehydration, not hyperglycemia. So this signals that this is not the central cause to the problem that we are facing right now. So my tip for you, if a factor happened days ago, or if it doesn't connect to the main abnormal findings, then it's probably not relevant. So feel free to pause this video and reflect on your answers and compare it with the rationals that I just discussed. Let's move on into our next item when you're ready.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month, then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It says here the patient arrives at the hospital with a blood glucose of 580 milligrams per deciliter post-saline bolus. At 11:50 a.m., laboratory results show a serum creatinine level of 1.2 milligrams per deciliter and potassium of 3.1 milliequivalents per liter. Your task is to indicate whether each action is appropriate, inappropriate, or contraindicated for managing HHS. So you already see the matrix. We have the nursing actions: start IV insulin infusion, continue 0.9% saline IV at 250 mL per hour, administer oral glucose gel, monitor serum electrolytes, recheck glucose every hour, administer potassium supplement, lastly, obtain an order for arterial blood gas. Here, I want you to carefully consider each action here. Make sure that you are matching each action to the correct category. Now, let's deal with start IV insulin infusion. What do you think with this? Well, this is appropriate, of course. This is very crucial in treating the HHS because this condition is defined by hyperglycemia, and we're talking about more than 500 milligrams per deciliter of blood sugar, right? Even the patient had more than that when he arrived at the clinic. So the insulin that we're going to administer via infusion, this will gradually lower the patient's blood glucose, and ideally the goal of the treatment should be about 50 to 75 milligrams per deciliter per hour. We don't want to drastically cause a rapid lowering in their blood sugar, because this can cause some changes in their cerebral function. We don't want to cause this rapid correction, because this can cause cerebral edema, and that is why the goal here is to have that lowering at a rate of 50 to 75 milligrams per deciliter per hour. Again, if you are going to correct the hyperglycemia very fast, this could shift the fluids very fast, and it can lead to cerebral edema. So take note about that. And since the patient's glucose upon arrival to the hospital is 580 milligrams per deciliter, when we are starting the infusion of insulin, definitely this is the right move to start reversing the effects of HHS. But don't forget, our ideal gradual rate of lowering is somewhere between 50 to 75 milligrams per deciliter per hour. Now, let's look into the next intervention. Continue 0.9 saline IV at 250 mL per hour. This is appropriate as well, because dehydration is one of the most serious issues that we have encountered in this patient. Their body is losing a lot of fluid through osmotic diuresis, which is caused by the hyperglycemia. And when we are continuing a normal saline at 250 mL per hour, this is going to help correct the fluid deficit gradually and safely. And the patient's creatinine level is 1.2 milligrams per deciliter, which suggests that the kidney function is still adequate. So this rate of IV infusion is safe to keep the patient rehydrated at this specific rate. And this is intended to stabilize the patient's blood pressure. When you go back into the vital signs, the patient's blood pressure is somewhat in the borderline low, in the 90 systolic, so you pay attention to that one. Now, let's look into the next intervention. It says administer oral glucose gel. Obviously, the patient is already hyperglycemic, so this is inappropriate. This is going to make things worse, and the more that you will see symptoms of HHS if you're going to add fuel to the fire here. Now, let's look into the next intervention. Monitor serum electrolytes. This is appropriate. This is very critical here, because whenever there is polyuria, and if you are going to replace the patient's blood volume through that bolus, and if we are going to initiate, if we are starting the insulin infusion, this can cause changes in their electrolyte levels. So it's very important that you are going to keep track of the patient's electrolytes, especially the potassium and sodium. All right. Now, in the scenario, it said that the patient's potassium is 3.1. And remember, when insulin is started, it will even push more potassium into the cells. So the more that it can lead to hypokalemia. So you got to be careful when you're administering the insulin this time. So you have to regularly check the patient's electrolyte counts as ordered to prevent complications like arrhythmias, muscle cramps, and respiratory weakness. So you pay attention to the hypokalemic manifestations. Next intervention we have is recheck glucose every hour. This is appropriate. We know that frequent monitoring of the glucose is going to be critical here to manage the HHS. So make sure that the blood sugar is coming down at a safe pace, not too fast. Again, go back into the gradual pace of lowering the patient's blood sugar, because if we are causing rapid drop in their blood sugar, it can lead to cerebral edema. All right. Looking into the next intervention, administer potassium supplement. This is appropriate, as we know that the patient's potassium level is 3.1. That's hypokalemia. We definitely need to replace that before patient can start having those arrhythmias. And remember that the patient is still getting the insulin infusion. This can cause the potassium ions to go inside the cells. So we want to make sure that while the patient is still getting the insulin infusion, we are also replacing the potassium. So kind of even out the numbers here. And as long as the kidneys are working properly, which they are, because the creatinine level is 1.2, then it's safe for us to administer the potassium replacement intravenously at this point. All right, so we are checking that appropriate box right there. Now let's look into the last intervention. It says obtain an order for arterial blood gas. What do you think about this one? Well, in this case scenario, it's inappropriate. This is not necessary in this case because in hyperosmolar hyperglycemic syndrome, it's totally different from diabetic ketoacidosis. There is no significant acidosis and there is no large buildup of ketones in this condition. And the patient's presentation does not suggest a respiratory distress or severe metabolic issues that would require us to check for their ABGs. So unless there's a clear reason to suspect acid-base imbalance or maybe a compromise in their respiratory function, then ordering an ABG would be unnecessary, and it's not going to be helpful in this case scenario. All right, feel free to pause this video and reflect on your answers. And when you're done, let's go right ahead into our next item number.
Before we move ahead, here's something you shouldn't miss. If your goal is to pass the NCLEX in just 1 week or 1 month, then the fastest and most effective way is to enroll in our complete online NCLEX review crash course. This course is a one-stop solution, a reliable shortcut, and a proven method with a solid 99% passing rate. More than 5,000 students have successfully passed the NCLEX by using this course. Here's exactly what you'll get. 100-hour mini crash course perfect for those who want to pass within a week. 300-hour comprehensive lectures covering 300 essential NCLEX topics that are commonly tested. 5,000 real NCLEX questions. Prepare with real exam questions and eliminate surprises. 15 full practice tests, including CAT simulations, simulate the real exam for a stress-free experience. Exclusive ebook plus 1-year access. Study whenever and wherever you want. Seats are filling up quickly. Enroll now to save 70%. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's continue with the topic.
4. It says here the nurse educates the patient on managing adverse effects of resuming glipizide to prevent future HHS episodes. Obviously, we have a bow tie. And your task is to identify the primary adverse effect of glipizide. 2 key teaching points and 2 patient statements indicating understanding. our main focus this time is just the glipizide, not metformin. All right, so we have the following choices for the adverse drug effect. One is nephrotoxicity, hepatotoxicity, lactic acidosis, hypoglycemia, gastrointestinal upset. Now, what do you think would be the most appropriate adverse drug effect for the glipizide? Obviously, that's hypoglycemia. And I want you to recall that glipizide is a sulfonylurea, which works by increasing insulin release from the pancreas. And the problem here is it's going to keep releasing insulin even when the blood sugar is not high. So after a patient recovers from the HHS, their system is more sensitive, and the glucose lowering effect of the glipizide can swing them too far in the other direction. So that's why hypoglycemia is the most identified drug effect or adverse effect for this case. So this is especially likely if they're not eating consistently or are more insulin sensitive after the episode. So the bottom line here is hypoglycemia is the most important adverse effect to monitor in patients when they restart taking the glipizide after the HHS. Now, looking into the incorrect options, such as gastrointestinal upset, well, some people may feel a little off when starting any new medication, but here, gastrointestinal upset is not a major issue with glipizide. This is something that you can associate with metformin, which can cause nausea or maybe diarrhea in some patients. Now, looking into lactic acidosis, this is a serious adverse effect associated with metformin, especially in people with kidney or liver issues, but not glipizide. We have hepatotoxicity, is not commonly seen with glipizide, and there is no routine recommendation to monitor liver enzymes unless there are other concerns as well. And lastly, nephrotoxicity. This is also not typical of glipizide, so eliminate this one. And this drug doesn't really accumulate in the kidneys like metformin, nor does it require renal dose adjustment in the same way. And that's why I want you to recall the differences between the two drugs here, glipizide versus metformin. Now let's head into the two teaching points, and the options are: report muscle pain or weakness, check glucose if feeling shaky or sweaty, report persistent diarrhea to the provider, monitor for signs of infection, discuss dose adjustments if symptoms worsen, take medications with food to reduce nausea. The answers for the two boxes here includes this one: check glucose if feeling shaky or sweaty, because these symptoms are the early warning signs that the glucose is going down. And if you are teaching the patient to recognize this, they can appropriately respond to them by checking their glucose, maybe with the use of a glucometer at home. And this is one of the best safety strategies to preventing severe hypoglycemia. The other answer is discuss dose adjustments if symptoms worsen. Now, here's the deal. If a patient is frequently treating lows, I'm talking about frequent hypoglycemia with snacks or maybe taking juice, and if it's not enough to keep treating the symptoms, then the patient might need to have their dose of the medication lowered. And that's why it's very important that our patients need to call their provider if their symptoms keep happening. If they encounter many episodes of hypoglycemia, this is really going to be a problem for them. It's not just annoying, it's a sign that the treatment plan might be too aggressive. So make sure that they are going to contact their healthcare provider to possibly adjust their glipizide dosing schedule. Now let's look into the two boxes here for the client statement. And the options are: I'll tell my doctor if I have persistent diarrhea. I'll take my pills with meals to avoid stomach issues. I'll check my glucose if I feel shaky or sweaty. I'll call my doctor if I have severe muscle pain. I'll report any yellowing of my skin to my doctor. I'll increase my fluid intake if I feel thirsty. Now, what do you think would be the answer here? One of the answers is I'll check my glucose if I feel shaky or sweaty. This plainly reflects that our patient understood those symptoms of hypoglycemia. And when they're going to check their blood sugar promptly, they can prevent serious complications like seizures or syncopal episodes. The other answer is I'll increase my fluid intake if I feel thirsty. This statement simply reflects that they understood that frequent episodes of hypoglycemia are not normal and should be reported immediately, and they should not just treat on their own without telling their provider. So this one is a cue that the medication dose may be too big for them or maybe too strong, or that the timing of food and medications needs to be adjusted as well. So definitely this patient will have some adjustment in their schedule of the drug intake and also their food intake. Now let's look into the different incorrect statements. So if you selected, I'll take my pills with meals to avoid stomach issues. Well, as I have said earlier, this is something that is associated with metformin, not glipizide. And if you selected, I'll call my doctor if I have severe muscle pain. Well, this is something that you're going to teach a patient on metformin to recognize potential lactic acidosis, all right, but not for glipizide. If you selected, I'll report any yellowing of my skin to my doctor, well, this sounds like you're looking into liver problems like jaundice, which again is not a common concern with glipizide. And if you selected, I'll tell my doctor if I have persistent diarrhea, well, once again, this is metformin territory. This one is not relevant to glipizide education, and this one doesn't show understanding of glipicide's main risks. So let's do a quick review here. When you see glipizide in the treatment plan, think of hypoglycemia. And if you see metformin, think about gastrointestinal issues and lactic acidosis. So make sure that you always match the teaching and adverse effects to the specific mechanism and risk profile of the drug. All right, let's move on to our next test item, number 5.
Before moving ahead, I have some exciting news for you. If you are determined to pass the NCLEX within a week or a month, then your best option is to enroll in our complete online NCLEX review crash course right now. This course is a comprehensive all-in-one solution, a guaranteed shortcut, and a proven method to pass. Over the last 5 years, more than 5,000 students have successfully cleared their NCLEX exams using this course with an impressive 99% passing rate. Here's what you'll get: 100-hour animated mini crash course, ideal for those who have limited time and want to pass in just 1 week. 300-hour comprehensive recorded lectures covering 300 high-yield NCLEX topics that the exam loves to test. 5,000 real NCLEX questions, practice with actual past exam questions for better preparation. 15 full-length practice tests, including CAT simulation. Feel confident before your real exam day. Exclusive NCLEX ebook, the ultimate guide you need to pass. 1 year full access. Study anytime, anywhere at your own pace. This is a limited time offer. Enroll now to grab 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. All right, now let's dive into the topic.
It says, on day 3, the nurse is determining the patient's understanding of ongoing patient education provided during hospitalization to prevent future hyperosmolar hyperglycemic state episodes. From the list of 10 statements the patient provides, drag and drop the 6 most important strategies into the box below, ranking them from highest to lowest priority for identifying and managing dehydration-related HHS triggers to demonstrate correct understanding of the education. Hang tight. We have the options at the bottom. All right. So One of the options here, we have I will drink electrolyte sports drinks every day to stay hydrated. I'm going to check my blood pressure twice a day at home. I'm going to look at my urine color every day and drink more water if it's dark yellow. I will use my fitness tracker to make sure I get 10,000 steps each day. I'm going to avoid exercising outside when it's hot to keep from losing too much fluid. And I will take water pills from the pharmacy if I feel bloated. I'm going to drink a couple of energy drinks every day to stay energized. I will check for dry mouth or feeling really thirsty and drink a glass of water every hour if I notice those signs. And I will weigh myself every morning and call my doctor if I lose 2 or 3 pounds in a day. And I'm going to stick to water or unsweetened tea and avoid sugary drinks like soda. So use your clinical judgment here. Prioritize the statements to identify those statements. Make sure that you are ranking them from the highest to the lowest priority in managing the dehydration related to the HHS. All right, when you're ready, let's get started filling these blanks. Now, the first priority that you should pick here is this one. I will check for dry mouth or feeling really thirsty and drink a glass of water every hour if I notice those signs. This is gold. Here, the patient is recognizing early signs of dehydration like dry mouth, thirst, and when he said that he's going to drink a glass of water every hour, that's a good decision for him. He's acting on them immediately to prevent any more fluid loss. So that's exactly the kind of symptom-based real-time response we want from this patient, because dehydration can also trigger the HHS, and this should be the first thing that the patient should think when managing their fluid status. Now, the second priority that you should select is this one. I'm going to look at my urine color every day and drink more water if it's dark yellow. This is great self-monitoring strategy because dark yellow urine can mean the patient is dehydrated. And when they pay attention to that and when they respond by drinking more water, then the patient is proactively preventing fluid loss from becoming severe. But it's not as immediate as the thirst, but still a very solid daily habit for this patient to acquire. Next, let's have our third rank, and that should be I'm going to stick to water or unsweetened tea and avoid sugary drinks like soda. This is an excellent dietary choice because sugary drinks spike glucose levels, which worsens osmotic diuresis, meaning more sugar in the blood can pull more water into the urine. And when they avoid soda directly, it can cut down on the cycle, and it's more of a general lifestyle move, which is why it's ranked a bit lower than compared to the other two. Now let's look into the fourth rank here. Your choice should be this one. I will weigh myself every morning and call my doctor if I lose 2 or 3 pounds in a day. This is a smart move because rapid weight loss, especially in a day, is often a sign of fluid loss. And by flagging this to the provider, the patient is being proactive. But since this is more about monitoring and not immediate action like drinking water, then that's why we are placing it on the fourth rank. All right, almost done here. The next priority should be this one. I'm going to avoid exercising outside when it's hot to keep from losing too much fluid. This is preventative and shows good awareness because hot weather plus exercise can cause them to sweat a lot and can lead to fluid loss. And if the patient already had an episode of HHS triggered by dehydration, avoiding the fluid loss in hot conditions is a very wise move. This is not really urgent day to day, but this is a good plan that they should keep in mind. And lastly, In the 6th rank, your answer should be this. I will drink electrolyte sports drinks every day to stay hydrated. This one is okay, but it comes with a caution because sports drinks can help replenish electrolytes, which is helpful after an illness like HHS. But doing this daily may not be necessary and could add unnecessary sugar or sodium, especially for a diabetic patient. And that's why it's at the bottom of the top 6, because it shows the patient kind of gets the idea, but the details need fine-tuning here. Now, let's talk about the remainder of the options that we did not really include in the prioritization. Like, I will take my water pills from the pharmacy if I feel bloated. Yikes. Water pills are basically diuretics. This is going to make the patient void some more or urinate some more. So that's the exact opposite of what we want in this patient. We don't want them to get dehydrated by taking the water pill. Now, if you selected, I'm going to drink a couple of energy drinks every day to stay energized. This is a major red flag because energy drinks are loaded with sugar and caffeine, and both can increase the blood sugar. It can cause diuresis, it will worsen the dehydration, and it can increase the risk of another HHS episode. And this would send the patient back to the hospital way fast. Now, if you selected, I will use my fitness tracker to make sure I get 10,000 steps each day. Remember that with exercise, that's a good part of their lifestyle. But when this is talking about 10,000 steps each day, this is not really going to help with the hydration or in managing their HHS triggers, because if they're doing lots of exercise without proper hydration, especially when they are exposed under the heat, this could actually make things worse, even though you think that this is a healthy behavior, but it's not the focus here. Look into the 10,000 steps each day, so it's not really going to help the patient, especially that it did not say about rehydrating, right? Now, we have the next statement. It says, I'm going to check my blood pressure twice a day at home. Well, this is something that you can use whenever a person may have issues with high blood pressure, but it doesn't tell you anything about dehydration or blood sugar levels. This one is not harmful, but it's not just helpful for this case as well. And so for this test item, I want you to make sure that the solution that you're looking for must be directly linked to the underlying cause of the condition, and the action should clearly reduce the risk of the condition recurring. And so the strategy that you should be using in selecting the options must be safe, it's evidence-based, and appropriate for the patient to carry out independently. And the response must address the patient's specific risk factors, such as missing their medications, the dehydration, and also alcohol use. All right, when you're ready, let's proceed to the next test item, number 6.
Before moving ahead, here's something you need to hear if you're feeling anxious about passing the NCLEX, especially if you're aiming to do it in 1 week or 1 month. Then our complete online NCLEX review crash course is your answer. This is your shortcut to success, a tried and tested course with a 99% passing rate. More than 5,000 students have achieved their NCLEX goals using this course, and now it's your turn. Here's what's included. 100-hour animated mini crash course, perfect for last-minute preparation to pass in just 1 week. 300-hour comprehensive lectures covering 300 high-yield topics that the NCLEX loves to test. 5,000 real NCLEX questions. Train with real exam-style questions and be prepared for anything. 15 full-length practice tests, including CAT simulation. Build your confidence with realistic exam experiences. Exclusive NCLEX ebook and 1-year access. Study whenever you need without restrictions. Don't let this opportunity slip away. Enroll now at 70% off. Visit our website to enroll in our complete NCLEX review crash course. The link is in the description. Now, let's jump into the topic.
It says, on day 3, the nurse prepares discharge instructions. The patient has a history of missed metformin and glipizide doses during a recent illness, irregular glucose monitoring every few days, and heavy alcohol consumption 2 nights before admission. So I want you to pay attention to the different tests obtained in the duration of day 1, 2, and 3. So upon arrival to the clinic, his blood sugar was 650 milligrams, and it went down to 550 when he arrived in the ED. And on day 3, the blood sugar went down to 180, and so forth. So I want you to carefully scan into the results here, but our main focus this time is for you to follow the instructions here on this test item. It says, categorize each discharge instruction by checking the appropriate box under essential, beneficial, but not essential, or not relevant to preventing future HHS episodes. And here's the matrix. So you will see here the discharge instructions. One of those is establish a sick day protocol with provider and input to adjust medications and maintain hydration during illness. The next one is monitor blood glucose 4 to 6 times daily, increasing to every 2 hours during illness. Third, schedule quarterly hemoglobin A1C tests to monitor long-term glycemic control. And the fourth one, limit alcohol to 1 drink per day and check glucose for 24 hours afterward. Lastly, track carbohydrate intake to optimize glycemic control. Don't forget, you're going to check the box where it's supposed to be. So the discharge instructions should be associated to either one of the options: essential, beneficial but not essential, or not relevant. Now, looking into the first discharge instruction, the answer for this one is essential, because the patient's HHS was triggered during a time of illness. He was sick with an upper respiratory infection, and he also missed doses of the metformin and glipizide, which are both crucial for controlling their blood sugar. Now, when he was sick, the body naturally produced more stress hormones like cortisol, which actually contributed to the hyperglycemia. And also, when the patient stopped taking those 2 anti-diabetic medications at the same time, contributed, or it actually was the reason why there is hyperglycemia. And so when we are talking about a sick day protocol, this is a personalized plan. It's going to tell the patient what to do when they're feeling unwell. And so this will outline what should they be doing with their medication, if there's going to be a change in the dose, and how much fluid they're going to take when they're sick, and when is the right time they're going to call the doctor. So this is a good recipe in order for them to prevent another HHS episode, because this is going to give them a clear instruction of those actionable steps when things start to go off track. And so if they're not going to follow the sick day protocol, then the patient will end up guessing, as we saw in the start of the case scenario. So it's going to be a repetition of the problem. Now let's look into the next discharge instruction. The answer to this one is also essential, because the patient only checked their blood sugar every few days before admission, and that's likely trying to drive blindfolded. And with the diabetes, especially if the patient's medications like glipizide, which can affect insulin secretion, then they need frequent checking to stay ahead of any highs or maybe hypoglycemia. And during illness, the blood sugar can change very quickly. And so they need to catch even a spike early on to prevent more of issues like HHS. So when they check their blood sugar every 4 to 6 times a day, so this is gonna give a good day-to-day picture. And if they are sick, they need to check their blood sugar at least every 2 hours to help detect dangerous hyperglycemic trends. And so this is definitely essential for them to prevent more HHS episode. Now, let's look into schedule quarterly HbA1c tests to monitor long-term glycemic control. The answer to this one is beneficial, but not essential, because the hemoglobin A1c is just like a big picture snapshot. It's going to help identify, or if it's going to help us, it's going to tell us how the blood sugar has been controlled in the past 2 to 3 months. So this one is important for long-term management, but let's be real. It's not going to help the patient in the moment when they are sick and when their blood sugar is spiking rapidly. Even though this one is a good indicator, or it can actually keep the patient in check in the long term, but then again, this is not going to catch the patient's sudden hyperglycemic spikes, and it's not going to help prevent the HHS by itself. Now, let's look into limit alcohol to 1 drink per day and check glucose for 24 hours afterward. This is also beneficial, but not essential. This one is a good tip, especially since the patient had heavy alcohol use just before hospitalization. And we know that alcohol can mess with the liver function and the glucose levels, sometimes causing delayed drops or spikes in the blood sugar, especially if combined with medications or skipped meals. And that said, occasional alcohol use is not the main trigger of HHS unless it's combined with poor glucose management. So it's a contributing factor, but not as directly linked to HHS as skipped meds or the patient's illness. So that's why we are going to label this as beneficial, but not essential. Lastly, we have track carbohydrate intake to optimize glycemic control. Well, this one is always helpful for managing diabetes, especially if someone is insulin dependent or if they are taking meds that affect insulin. And this can help smooth out the glucose levels over the long haul. But again, this patient's HHS was not caused by eating too many carbohydrates. His HHS was triggered by the illness, the non-compliance to taking the 2 anti-diabetic medications, and the poor monitoring at home. So we know that carb counting is very smart, but it's not the most urgent priority for preventing another HHS episode. So here, let's do a recap of what you learned from this unfolding case study. So going back into test item number 1, that was a hotspot. So here you identify the hallmark signs of HHS, and don't forget about the hyperglycemia, the patient's confusion, the dehydration, polyuria, while you are filtering out those vague symptoms like nausea or general vital signs that have changed. Now let's have test item number 2. That was a drag and drop. So in that test item, you pinpointed the missed diabetes medications as the main cause of hyperglycemia, with illness, dehydration, and stress as contributing factors. And you also correctly ruled out alcohol as a likely trigger. For test item number 3, that was a matrix multiple choice. You chose the appropriate hospital interventions for the HHS, including the administration of IV infusion insulin, IV fluid replacement, frequent checking of the blood sugar levels, and electrolyte monitoring, while leaving out those unrelated treatments like oral glucose or ABG testing. Now in test item number 4, that was a bow tie. And in that item, you focus on the risk of hypoglycemia from the glipizide. And you also pointed out the symptoms and avoided unrelated teaching topics like gastrointestinal upset or rare side effects. Now we have our 5th item, that was extended drag and drop. So in that item, you prioritized smart strategies for preventing dehydration in HHS, such as checking for thirst and avoiding sugary drinks and staying cool, not exposing themselves from under the heat, and also excluding those irrelevant practices. And lastly, For test item number 6, that was a matrix multiple choice. In that item, you selected those key discharge instructions to prevent future HHS episodes, like a sick day planning or protocol, and frequent glucose checking, while recognizing that lifestyle tips like carb tracking and limiting alcohol are helpful, but secondary. So I hope that helped you in filtering the answers, the options in each test item. So that's all for now. If you find this video helpful, don't forget to hit those buttons, subscribe, like this video, and share this content with your friends studying for the NCLEX. Thank you for watching, and I'll see you in our next review session.